Good morning. It is great to be here. Y'all were supposed to dress up for Cardiology Day. No, I obviously don't have my luggage yet. So this is strikingly similar to what I wore last night, and be strikingly similar to what I probably wear tomorrow until I get some luggage. So here's our first question of the day here. I don't know if we're doing the clicker thing or if you want to do this in your head.
Yeah, we'll do the clicker.
We're loading it up. So aviators with coronary artery disease can enter pilot training in the United States Air Force under which of the following conditions? So complete revascularization and normal non-invasive studies, or complete revascularization and normal non-invasive and invasive. Do we cath everybody? Or after consent of the aviator that they are increased risk of death while flying secondary to CAD, or do we just not allow any people into pilot training with coronary artery disease? Is it going up? This doesn't cut into my time, Ed.
Tim disappears for 5
minutes. That's all right.
So we'll skip the question.
So make a mental note, and we'll see where we stand. So I've taken out my disposition slide. So, of course, I have no disclosures. I don't work for any drug pharmaceutical company, and everything I say is my own and not that of the Air Force, the United States government, NATO, NASA, or FAA, or anybody else that I provide advice to. So this is just to remind you, I think last year I told you all this, 1 in every 3 people in the world is ugly. So if you look to your left and that person looks okay, and you look to your right and that person's okay, then guess what? Well, actually y'all look good, you're good looking. But the same is true of coronary artery disease. 1 in every 3 of us have coronary artery disease, and probably even more than that, because the majority in this room is probably over age about 35 when it increases. But as you can see, I usually tell my patients it's based on the decade of life. You're in your 60s, you got a 60% chance of having some cardiovascular disease. In your 70s, you got a 70% chance, so on and so forth. The big thing I want to make everybody very aware of, though, is the majority of folks that have cardiovascular disease are not the old people over age 65, 70. It is the young. Of the 71 million Americans that have disease, 27 million of those are over 65. That's only 38%. So the majority are young. The majority are going to be the folks we're taking care of and flying airplanes. These are just some statistics, the latest ones I could find from 2011. This is the prevalence in the United States. About 1/3 of folks have hypertension in the Air Force. I just looked up some of this data, and we're just slightly less than this, but we still have over 20%. Tobacco, 24.5%. This is, of course, going down significantly, although teenagers, it's actually leveled off, and now that I have a teenager in my household, this is actually leveled off and starting to maybe even go up. So we got to watch this very closely. LDL levels about 38%. BMI, as you know, is the new epidemic. We're getting bigger. And 67% of folks in the United States have a BMI greater than 25. And in the Air Force, what do you think that is? In the United States Air Force, I just looked this up, 51% of our Air Force in all personnel actually have a BMI over 25. And here, 32%, we said, of kids. Of the 67, though, over 33% of Americans are obese with a BMI greater than 30. And in the Air Force, believe it or not, 15% of the United States Air Force is actually considered obese with a BMI over 30. So that's the new epidemic. That's something we have not recognized. It's not a risk factor yet, but it is soon going to become one, I believe. So here's all the modalities. I showed you this slide last year when I got to the Aeromedical Consult Service 4 years ago. I saw a wealth of information. In fact, when I was going to become, what are you going to do out of fellowship? What are you going to do next? I talked to Dr. Strader, I talked to Dr. Cryer, and I said, this looks pretty cool. I get to fly around in fighters up at Randolph Air Force Base, and you guys have this data. So I go to look at an EKG, and I says, you've got every old EKG, right? So I'm looking at an EKG, I say, I want to see this pilot's old EKG, and they said, you got to go downstairs, it's in microfiche. I said, micro what? The light bulb broke on the machine, so I could not look at the microfiche. So we decided very quickly that I had to get all this data, a wealth of data, over 1.2 million studies, as we said earlier, into something that we could actually use. We also had an EKG machine that looked like this. So we said, hey, let's update everything. So before I got there, actually, Dr. Cryer, Dr. Strader, and Dr. Sky, which were at the ACS, got all brand new EKG machines, brand new echo machines, brand new treadmills, brand new Holter monitors, which is what this is. Got all brand new systems and put it into a PAC system. So every piece of data we get now is not going to a box, it's going into our packs. When I got there, I said, what about this 1.2 million studies? And this is called the EKG Library, but it includes cardiac catheterization, it includes nuclear stress tests, it includes anything that they've done cardiac-wise. Let's take all that, let's throw it in here. So we did. We uploaded all those 1.2 million studies, put them in here. Then I added 3D echo. Why did I do 3D echo? Because anybody who had coronary artery disease in the United States Air Force got a thallium nuclear scan every year. Thallium is a lot of radiation, and we can do the same thing with echo imaging. The problem is if you, when you do a stress echo, which I'm gonna go over today, you gotta get their heart rate up, gotta take a picture as soon as they get off the echo, as soon as they get done exercising, you gotta take another picture while their heart rate's still up. Even our aviators with cardiovascular disease will go 17 METs on this. They'll be at an incline of 25 degrees and running. And by the time we get them off to the bed to take the echo, their heart rate plummets, which is a good sign, but it's very hard to do a study. So that's why we did a lot of nuclear. Well, what I found out is 3D echo, it's not so much the 3D image, but it omnis for you. You put the probe right here and it takes multiple pictures. You put the probe down here, it takes multiple pictures. So I was getting onto our echo tech saying it can't take you a minute to get an echo. They says, well, look at this 3D. We looked at 3D. So now we put them on the exercise, jump on the bed, and we get an echo within 7 seconds. So now we can get good data. We've completely gotten rid of nuclear stress testing. Unless this is equivocal, that will be the next step we go, because even though I really do like to cath, as Christoph told you, or alluded to anyway, which I can do in 12 minutes and give you a lot less radiation than most CT scans, but as he said, it is uncomfortable, so we try to do non-invasive testing the best we can. And the next big thing is this. Why are we sending stuff by mail? Why are we sending stuff across the country from Afghanistan, Iraq, even here, Landstuhl, and we're getting studies. It's taking forever to get to us by mail. We're in the digital age, right? We can get this all sent electronically. As of today, we have 11 sites throughout the United States that are sending me studies electronically, and by the end of the year, I hope to have all 238 flight medicine clinics. We actually just got a letter signed. It's going to go out to all the flight docs, and we're going to receive everything electronically. This is a big deal. If you're in Iraq, Afghanistan, if you're here in Europe, anywhere, and you're at an American flight medicine clinic, you push a button for the EKG, and it pops up at my screen there at Wright-Patterson Air Force Base. So these studies can be done immediately. Then we can send techs out throughout the world to do echoes for us, and we can read them there. You don't have to send a cardiologist all over. Just leave me in Ohio, or send me back to Texas would be fine. So here we go. United States Air Force, we have to have policy, and we alluded to this before. You've got to have evidence-based medicine. A lot of what we've done is based on expert opinion. In fact, the 1999 cath guidelines were Christoph just went over that said, hey, high-risk occupations should cath them as a level C evidence. It was based on expert opinion. It was 13 years ago. So what we've got to do is we've got to stop getting away from this expert opinion. Some of you all here will remember the old A-Guard. I was reading through some of those A-Guard manuals. I still have them sitting in my office, that the basis of a lot of stuff that we do still in flight medicine. It's time to get the evidence, and we've got the evidence. We've got tons and tons of data, and now the data here, everything's electronic, so everything's saved forever. If we work together, we can make a big difference, not only in the world of aeromedical cardiology, but outside. You know, when I have pilots, I have a dozen pilots that scored a 90% or better on their PT test. I have 3 that scored 100% on their PT test. I have 1 that came in 6th place in the Ironman triathlon, and I have 1 that was running a marathon. All of those patients, 12 total, went across the finish line and had an MI right there. All of them had no risk factors, except the majority had low HDLs, and a lot of them had family history, but that was all they had. So otherwise, very healthy, very, very, as good as you can get, doing everything you want to prevent heart disease, yet they still had an MI. Why does that happen? We don't know that, because as Ed told you, in our private practice and where we learn, the average person that has cardiovascular disease is going to be older. And so we have a great wealth of information that we could share with the world. So I'm going to go a little different than, the policy. I explained the policy last year. I'm going to kind of embed the policy in the Air Force in this talk. But what I really wanted to do is explain to everybody here every test, or at least the 5 big tests we do in cardiology. So you will have a thorough understanding of why we're doing what tests we're doing. And when I give this talk in a civilian-wise, I usually get 5 or 6 new people to come see me in clinic, and I get lots of calcium scores. And so and even today, I'm sure some of you are going to meet me back here. This happens every time I give this talk. They say, hey, look at me. I've got this and this and this and then this. What do you want to do? And so I've arranged to cath whoever wants to be cathed over at Landstuhl at the end of the conference today. And we can also do CT scans. They've got a great CT scanner. It is an Army base, so they've got everything. So So I really want you to understand all about how we do imaging. So sometimes you can tell a high-risk patient, just based on EKG. So there's a mild cardiomegaly. No, I'm just joking. So here's the problem with cardiovascular disease. We talked about this already. 50% of people who show up with cardiovascular disease do so by presenting with sudden cardiac death. So you're alive and then you're dead. So that's kind of hard to screen for. And these are two casts that I've done personally. This person had 3-vessel disease. This one had a completely occluded LAD. Both these people had never been to the doctor before and were very active. So it's very hard to, does this work? Here we go. So this is atherosclerosis. Let's just talk about this a little bit. This is a little video. So we're going to go inside this vessel right here, and we're going to look at the inside of an artery. These are the blood cells. And what we think the atherosclerosis, and we think it is caused by a disruption in the lining of the vessel, which is the endothelium. We think that's what caused it. We know if you have other disease processes such as diabetes, you're much more likely to have endothelial dysfunction, but something causes damage to that wall. And when that happens, then you get these little white things are going to be your platelets. These are red blood cells that start coming in here, and we get inflammation. These are inflammatory mediators. Inflammation is what we're looking at more and more and more into the plaque burden. So here we've got this guy is a big macrophage. Macrophage is going to kind of try to come and save the day. We also know that we want to cover up this damage. We want to fix it, and we do so by inflammation. There's also a lot of fat. There's free fatty acids. There's going to be cholesterol, and they're going to combine with this. These are these free fatty acids, and then they're going to bind here with the macrophage, and it turns into what's called a foam cell and looks really ugly. That's your ugly foam cell. Now what they're doing is we have a rupture. We have a problem with this wall. So it's going to go and try to, I think of it like spackling. When there's something wrong with the wall, you put the little spackling and try to patch it up. So that's what we're trying to do. And I want to stop this right. I should have backed that up a little bit, but we'll wait. So here, now you're getting disruption. Now the inflammation's so bad, these are going to be smooth muscle cells. So we're going inside this. You've heard about the different layers of the endothelium. So now you've disrupted every single layer. You're running out of options here. You've got this rupture. You've got this plaque that's about to rupture. These are smooth muscle cells going towards the surface. There needs to be some good music right here, huh? I just came from the ACC meeting. They would give you 3D glasses so you could see this in 3D. It was pretty amazing. Of course, these were people trying to get you into listening about their drugs. Right here. So here's our lining now. This is getting bad. Let's just, oh my goodness, I stopped it. Oh, you didn't get to see it rupture. Anyway, sorry, I meant to stop it at home when I did that. It stopped it. So you got that plaque building, right? It's building, building, building. It was like you just lost the climax of the film. Sorry. It builds and builds and builds, and then if it stays right there, that is a stable plaque. What your body will do is it'll put calcium on that plaque. If it can put calcium on that plaque, it stops it from rupturing. That calcium is probably stable plaque. What happens, though, is it can erode. The minute it erodes, it ruptures, and then you have your heart attack. And that's what you would have seen if I hadn't just messed that up. We'll see if we have time at the end. I can show you that again. So then it ruptures, and then you have your heart attack. That's bad. What is a vulnerable plaque? What makes it rupture? Because that's a big, big question. As Christoph just said, if we have that and it slowly gets worse and worse and worse, and it almost occludes that artery, then what's going to happen? You're going to get chest pain when you exert yourself because you can't increase your blood flow. You're going to be fine at rest. Does that make sense? If it ruptures, though, what ruptures? It's not the 90% blockage. It's the 40% blockage. It's the 50% blockage. If you did your CT angiography, you're going to find a 40 or 50% blockage. And right now, the policy in all of our militaries is we'll still let you fly with that 40 or 50% blockage. If you're already a trained aviator, we find it later, we'll let you fly because you probably can do very well with aggressive risk factor modification. But what's going to say that thing doesn't rupture? We really don't know. And there's no perfect test for that. So we're going to talk about the test. Here's one test. Here's a nuclear stress test. This is a nuclear stress test. You see, we cut the heart in different ways. We give you this nuclear tracer. There's two types we use. We usually use thallium, which is very radioactive, or we use technetium. Then you put it on something that gets it there. So you've heard of Sestamib, you've heard of MyoView. That's just something that grabs the technetium, takes it up to any part of your heart which has blood flow. So this is the heart. We cut it in different sections: anterior wall, inferior wall. Here's the lateral wall, septal wall. We cut it here in the horizontal long axis. Now we're just looking kind of at the lateral wall and the inferior wall, and then you right here, you can look at the anterior wall and the inferior wall. So all we're doing is we're giving you this nuclear tracer, heart's alive, heart lights up. So let's put a blockage right now. We're going to put a blockage right here in this artery. Let's pretend this is an artery that's going to, say, the lateral wall. What's it going to show? It's going to drop out. So has this person, do they have ischemia? Do they need cath? What does this person have? This person already infarcted, right? That part of the heart is dead. This is what it looks like. At stress, what's it going to look like? It's going to look like this. What's going to look like at rest? It's going to look like this. Total blockage. Nothing's going there. Very easy, right? What if we have a partial blockage, though? This is what we have here. We have a partial blockage. Well, at rest, it's fine. You got normal perfusion. Blood can go this way, can go this way. At rest, you got normal perfusion. However, what would happen if we stressed you? If we put you on a treadmill, or if we gave you medicine to stress your heart, what would happen? Well, the blood flow over here is going to increase. The blood flow here is going to be significantly less. So that if we gave you another dose at stress, that part of the heart turns dark. Does that make sense? So here, it's at stress. Here is at rest. We say, oh my goodness, you probably have a partial blockage. Then we go on to do coronary angiography. So this is a very neat study in that it's very physiologic. We're getting a physiological example of what's going on. So how blocked does this have to be? Well, it has to be probably greater than 70%. Greater than 70%, and you're going to get that dropout with exercise. If it's above 90%, you might get a little area even at rest that doesn't quite perfuse as well. But definitely at 70% or greater blockage, you're going to see that as far as we know. So this is what it looks like. This is the studies we read. This is going to be we see a stress, then we see rest. Stress, rest. Then down here we look at here. This is stress, this is rest. This is stress, this is rest, and we're looking for differences. In this example, there's not really much of a difference. We'll say that's a normal nuclear stress test. Could the person have a 50% blockage? What would it look like? It would look completely normal. 60% blockage, completely normal. The only way it's going to show a difference is if they have a 70% or greater blockage. And if it was dark on both, then that's infarct. Everybody's got that? We're going to read some nukes this afternoon. There should be a test on this, right? So in predicting outcomes, sometimes it's even better in a cath. You won't hear me say that much, but sometimes it's better in a cath. So I can go in and do a cath. I see a 50, 60% blockage. Is that significant? Is it hemodynamically significant? Well, if I have a nuclear stress, I can know if it's significant, right? Because I'll see it drop out. So sometimes a nuke is better than the cath, and this was shown in this study back in '93. Now we have something called a flow wire. We actually stick a wire down the artery at the time of cath, look at the flow distal and before it, and it works just as well as nuclear stress. But still, non-invasive, as Christoph said, it's a lot easier on the body than having to do an invasive cath. We do a lot of nukes. Nukes reimburse $3,000. I'm encouraged to do these often when I work private practice because they make a lot of money. And we do a lot of them. Do a lot here in Europe too. You're number 2, not as bad as us, and then less throughout the country. So they did a lot of nukes. This is the first time in many years we're actually seeing a decrease in the amount of nukes. We're doing less and less now. They're getting very good. They're getting their radiation down to half of what it used to be. So this is a common theme. We're all trying to use a lot less radiation. We've got improved cameras. Notice you don't have to go into a tube. They actually have them where they can sit up now, and we can actually do this. We have ones that don't go all the way around you because, believe it or not, as we alluded to, some people don't fit through the donut hole. So we just have them sit there and we go around them. When I was in San Antonio, we would send people to SeaWorld if we couldn't fit them on our scanner. So this is what's wrong with doing exercise stress tests. I'm going to give you the benefit of the doubt and say 80%. It has an 80% sensitivity and 90% specificity, but our prevalence is about 5%. It's actually about 0.15% or 0.5% in our population, but let's say it's 5%. This is why I don't do exercise stress tests on everybody in the Air Force. If you took 20,000 patients, 5 times 20,000 is 1,000. So 1,000 of those folks are going to have significant disease. The other 19,000 are not going to, okay? Because we've only got a 5% prevalence. If you take an 80% sensitivity, 80 times 1,000, remember sensitivity is how likely you are to have a positive test if you have disease, you've got 800 true positives. The other 200 are going to be false negatives. 90% specificity, 90% of 19,000 is going to be 17,100. The rest are all going to be false positives. We don't care how likely you are to have a positive test if we know you have disease. We want to know how likely in all comers are we going to have a true positive test that shows that you have disease. So we take our true positives divided by our true positives plus false positives, and we've got a positive predictive value of 30%. That means if you have a positive stress test, your chance of actually having disease is about 30%. How about if you have a negative test? Well, negative test, true negatives divided by true negatives plus false negatives, 98%. You said it's a great test, 98%, right? Well, I had a 95% chance of just picking someone out of the crowd, right? I've only increased my negative predictive value by 3%. Let's do CT angiography. You can get almost to 100%. Okay, you've increased it by 5%. So it's very, unless we hit 100% negative predictive value, and most tests are not 100%, this is not a good test. So doing stress tests in everybody would not be a good idea. This is called Bayesian Theory. Bayesian Theory says if you have a small pretest probability, even after a positive test, you still have a pretty small post-test probability. If you have a hypertensive, hyperlipidemic, diabetic, overweight male who gets angina every time he mows his lawn, you don't need to do a stress test. Just go straight to cath because their pretest probability is so high that it doesn't matter what your test is going to show. So this is theory, though. It's theory. So we took 900 aviators. Remember in the old days, you came to the ACS for an eyeball problem, you could end up getting cathed, right? We put everybody on the treadmill and we cathed everybody. So we did exactly, everybody who came there got some kind of a test. We did a lot of normal caths. And what we found out is if you had a positive treadmill or a negative treadmill, your likelihood of having an event in the next 5 years was 0.5%. Didn't matter if it's positive or negative. It's a completely worthless test. Let's add thallium. It's a completely worthless test. How about fluoroscopy? Fluoroscopy means we put you in the cath lab, we hit on fluoro and see if you have calcium. Yay, you do have it, or nay, you don't have it. Yay, you did have it. Probably a calcium score of greater than 100 was 1.3%. They tried to publish this back in the 80s, and everybody at the American College of Cardiology said, you are silly. Calcium is nothing. And they laughed at us, and we did not get this published. And I want to republish the same paper. I even told them that at the ACC this year, because calcium scores are very important. How about looking at greater than 50%? We call anything over a 50% stenosis, we call that obstructive disease, but it's not hemodynamically significant. Remember, if it's not above 70%, you're still not going to see it on a nuclear stress, and there's probably nothing you need to do except aggressive risk factor modifications. But you can see right here, your sensitivity specificity is very low. Your positive predictive value, because we cathed everybody, is still lower than what I even showed you because I think our prevalence is actually less than 5%. Your negative predictive value is terrible. Your positive predictive value is terrible. The only thing that works out to be even a little bit helpful is fluoroscopy. So stress tests are not the way to go, and that we don't do those anymore in the Air Force on all comers unless you have a reason. What about calcium? Remember, we had our plaque right here that was about to rupture. If we calcify that plaque, we make it stable. Calcified plaques rarely rupture. It's actually a stable plaque. However, before it was calcified, what was it? It was non-calcified. So being a non-calcified plaque prior, we think that calcium is a pretty good surrogate for the stuff we can't see. I love calcium scoring. You can do this on the oldest calcium scanner you can find. In fact, they do that. They have them now in America. You can usually go to you can get one in a trailer now. They'll have these trucks come through town. Everybody come get your calcium scores, $49.99. You get your calcium score and walk out. In fact, I'm working at a hospital and we charge $100, so I will send them to the local Baptist church that's doing them in the parking lot for $50 and say, bring me your results. So right here, here's your calcium. If somebody has calcium, do they have coronary disease? Yes. Okay, so don't ever get a calcium score, got positive calcium, I'm going to go to a nuclear stress test, it's negative, you don't have coronary disease. Yes, you do. You have calcium in your coronary arteries, you have calcium you have coronary disease by definition. Here's the problem with calcium scores. A lot of us have it. White males in the United States, 70% over the age of 45 are going to have calcium. So here's me, younger folks have calcium, okay? It's very common. So we're still going to have some negative or false positive results, people who are not going to go on to have disease, all right? Here's our data. We looked at fluoroscopy. I told you about that. That's having calcium. We also looked at what's called this aggregate stenosis. So what we do is we cath people. We add up the lesions. Say you have a 30% lesion, 20% lesion, that's a 50% aggregate. So you have a 50 to 50, that's 100% aggregate. Does that make sense? We put them into these different quartiles. So we said, or tertiles, I guess. Less than 50 was 0.6% event rate per year over 5 years. And actually we have data out to 10 years now. 50 to 120 was 1.1, and then over 120 was greater than 3%. This is an article done about the same time we ran that data that showed a calcium score. As soon as you get a calcium score above 10, your event rate goes up over 1%. So that's under the 1% rule. 100 to 400, 1.14. You get over 400, it goes up to 3%. So anybody in this, we're just going to cath. All right. That study that Dr. Wonis was just talking about, the confirmed trial, I have it right here that we looked at, looking at CT angiography. They saw this too. They said if you get a calcium score over 400, you need to have angiography, be it CT angiography or be it invasive angiography. You need to have angiography. What do we do with the folks here in the middle? Well, then we can do our non-invasive testing, because if you have a positive non-invasive test, your event rates go way up over 20%. So this was what they showed in this. The 0.5, the aggregate stenosis that we showed based on angiography. And here's the CAC scores. 10 to 100 had a 0.5 to 1%. That was equivalent to when we found mild coronary artery disease. Right here, the 101 to 140, very equivalent to moderate. So what does this tell us? What a great surrogate, you know? You don't want us cathing everybody? Well, calcium scores may be a great surrogate to tell us that disease we cannot see. Is this calcified plaque going to rupture? No, it's the surrogate. It's the stuff we can't see. It's that non-calcified plaque that's going to rupture, that's going to cause problems. So very good. We love calcium scores. We require a waiver if you have a calcium score over 10. Let's talk about echo. So echocardiography. So now we've talked about, if we're looking at calcium scores, we're getting a little bit more of we've gone along physiology. That's our nuclear stress test. Now we've got anatomy. We can look at it. Here's more anatomy. The only way I can look at a heart, the CT surgeon looks at hearts a different way than I do. He holds them in his hand and looks at them. I can't do that, so what I do is echo. This is non-invasive. This can show us regurgitant lesions. We're going to get some echo lectures. That's why some of these movies don't work, but we're going to be seeing a lot of echo images later. This is your aortic valve. We got very good images now. It should have 3 leaflets. If it has 2, it's a bicuspid valve. This was just going to be an image just showing you this aortic valve. We put colored Doppler on it. We can see if any of the valves are leaking. This one actually, you can see the left main coronary artery right there. But very good way to show us a squeezing heart. So this image isn't, we couldn't get these to work, but imagine this heart is beating. This is the anterior lateral wall, inferior septal wall. All these walls should move in together. If they move in together, you got a normal, we think normal perfusion. This is 3D echo. We're using this a lot now to get a better look at these valves. So now let's occlude an artery, completely occluded artery. What's going to happen to the heart? And I'll show you this in a second, but the heart stops moving as well. And you can see regionality. Say the anterior wall is not moving as well, then you've got infarct there. That heart is dead, all right? What if whatever part of the heart's not moving is dead? Then we have something called stress echo imaging, and I think I have to escape out of this. Is this one I escape out of too? How do I get out of here? There we go. I was told to hit this little button right down here. This is my only echo image, so I got to have one to show you. Here we go. And I can pause. Excellent. That's why I got rid of the other picture as long as I have this. All right. Squeezing heart. See that squeezing heart? Over here, I'm going to tell you this is the anterior lateral wall, inferior septal wall. This is all anterior wall. This is all inferior wall. This is at rest on this side, so it should be squeezing very well. That's what a normal heart looks like. Over here, it's going to be at stress. And you'll notice this part of the heart is not moving as well at stress. See, moving, not moving. We're going to see it again. We'll watch this a couple times. Global hypokinesis. See how it's squeezing, not squeezing. It's all squeezing, it's not squeezing. See how we've lost that? So it can tell us about ischemia. So stress echoes not only tell me how the valves are working, but they also can show me ischemia. If they're squeezing, look, it's not squeezing as well, right? I can do this instead of thallium, and I don't have to give people all the radiation. So we do a lot of stress echoes now. I stress echo all of our CAD patients. And if I see a difference, now if it's not squeezing them both, that's infarct. But if there's a difference between stress and rest, then again, suggestive of one of those partial blockages, right? Because it's not getting enough blood flow at stress. So stress echo imaging, it's free for me because we work for practically nothing. And where's start the show? Start the show. And then now we have CT angiography. Love to do caths, and you know the caths that we do, it takes me on average now, I've got it down to 12 minutes. You come in to get a heart catheterization. From the minute the pager goes off and says the patient's on the table, I walk in, stick, get the artery, go up, I shoot dye in the arteries and pull out. I don't need to do any V-grams. I don't have to give many, because we already got good echo data. So in and out takes about 12 minutes. On average, I use 1.3 minutes of fluoro or a cine to take the pictures, and I use about 40 cc's of dye, so a couple tablespoons of dye. Very low radiation, very low dye load. And so CT angiography wasn't like that. In the past, it wasn't like that. You use 200 cc's of dye, and there's still a huge dye load, so that can affect the kidneys. Our guys are normally young and otherwise healthy, our airmen and air women. But the radiation now is down to less than 1 sievert. 12 millisieverts, what they used to use, was huge. So in the past, this background radiation that we used to be the #1 source of radiation in folks is now becoming all medical. Now we're radiating our people quite a bit. And unfortunately, MRIs of the heart are just not there yet. they're not as good. But look right here. So a chest x-ray gives you 0.02 millisieverts of radiation, where your CT angiographies used to do about 15 millisieverts of radiation. So that was 750. So as you can see, we preferred cath. Cath, yes, it's a little uncomfortable, but other than that, it was a lot actually safer for the patient. So, but now you can see we're getting this down closer to 1 millisievert. We're not using thallium anymore. We're using systemibine when we have to, but I've taken this and done all stress echoes. So we've gotten pretty much rid of all the radiation. Cath, if I have to do that, and my caths I would say are definitely 2 millisieverts or less. It's about the same as CT angiography, okay? CT angiography, though, if it is positive and you see greater than 50% stenosis, you have to go on to cath, right? And when you do cath, if I'm doing a heart catheterization and I see a blockage, we can go ahead and fix it also if that be the case. So again, CT is getting better. 2 millisieverts is what they say now on average with the Flash, these really good scanners, made by Siemens, which is based in Munich. I did get to play with a lot of their scanners at this ACC meeting. It's really cool. They're doing a great job on them. However, look at this coronary angiogram right here. This was done last week. This was done on Thursday before I left. There was a 50% stenosis on CT. And oh, I got to see that again. That's beautiful. Right here, this is the right coronary. They said right here. Now as you can see how it's bending right there, it's just a little bend. Got it at a bad spot on CT, and they actually called a blockage right there. There's no blockage right there. I didn't cath this guy just for that reason, though. He actually had been revascularized on the left and had a stent in his circumflex artery, which was the actual reason for this cath. And I didn't actually agree with the CT angiography. You've got to read a lot of these to be good at it, but still, you can see where that may have been construed at one point. That's a completely normal right coronary artery. It looks beautiful, and that cath took 8 minutes because I was out to prove something that day. So 1487 male aviators that we have cathed for various reasons. This is just to go over our policy. I had to embed this in here somewhere, right? That we've cathed. The event rates at 2, 5, 10, and 15 years was based on, like I said before, this aggregate. This is what we were going to use, the less than 50, greater than 50, but that was too big. We used this, and since we're very, I studied under Cryer for a couple years. Cryer studied under somebody else for many years. So we have very much the consistency there at the ACS, and that's why they can't, as Ed alluded to, they go down to the private cardiologist. They'll either say, yes, you've got terrible disease. Please come back every 3 months and bring your TRICARE insurance, and we're going to do all these studies. Or you get the opposite. Oh, you're absolutely fine. Go fly F-16s with your mild to moderate coronary disease. So everybody comes to see us, and that's why it's very cool. One of the greatest things about this conference is getting to know these 5 other cardiologists here. We talk all the time now. We send emails back and forth saying, what do you think about this? What do you think about this? Which is great. But again, because it's based on our data, which is very different, very, very different again than the population. So this is our current policy. These are in folks that already are trained assets. If you're already a trained asset in the United States Air Force and you're found to have minimal coronary disease, be it asymptomatic, or believe it or not, the data is exactly the same if you've had revascularization, including CABG, bypass surgery, or stents. What do we say, less than 50% aggregate? You can fly non-high performance. We're going to fly you annually. If you have moderate, that's at 50 to 120. We're not going to let you fly high performance anymore. And we're going to make you fly with another qualified pilot. This is called a 2C waiver in the United States Air Force. You can fly as or with another qualified pilot, non-high performance, and we will cath you. We used to cath you every 3 years, now we're going to every 5 years. This may be the perfect place to do CT angiography, so we don't cath these people every 3 to 5 years. I just changed this policy myself based on all our 3-year data. And severe coronary disease in aggregate less than 120, or any single lesion greater than 70, or a left main greater than 50, you don't fly anymore in the United States Air Force. What if you want to become a pilot in the United States Air Force? If you want to become a pilot in the United States Air Force and you already have known cardiovascular disease, we will not let you fly, okay? So we're not going to put you through pilot training and train you for $4 to $8 million, whatever it costs, and then turn around and watch your coronary disease maybe progress. How about revascularization? 30 air crew. So this is what Cryer hands me. Hey, we did 30 air crew. And these 30 air crew, they did pretty darn good. We had no deaths. We had no MIs. We just had a couple that needed revascularization. Annual event rate, 2.1%. Event-free survival rates, 97%. So we believe that these pilots should fly. In December 2008, he let them fly. In 2009, he retired. We now have 130 patients with cardiovascular disease flying in the United States Air Force. I used to lose sleep over this a little bit because I thought, oh my gosh, something's going to happen here. Nothing has happened yet. They all do very well. I see them every single year, and we continue to have very low rates. The only thing we're seeing is revascularization. Anything you read in the cardiac literature, when you put in stents, they beget more stents, right? They beget more cardiovascular disease. They're followed very closely, but no death, no MIs. We have to be very certain that they have all their risk factors completely under control. If they have high blood pressure, DNF, you're not flying. I had one guy call me up and he says, I had one flight surgeon call me up and says, the guy started smoking again. I said, DQ, no waiver. You can't smoke. Your blood pressure has to be perfect. Your cholesterol has to be perfect. All right, 6 months DNF. If you've been revascularized, I will recath you. Everything has to look good, 100% revascularization. Low performance only, as or with a co-pilot. So in summary, what should we be using? Best things in life are still free. They really are. You know, if you're over 80 years old, there's a recent study showed that for every lap you can do around a track, a quarter-mile lap around a track, for every lap you can do, you increase your life expectancy by 2 years. You decrease your risk of dying by 12%. We've got to get active. I agree. You know, every time I go to the ACC meeting where there's vulnerable plaque, what's going to rupture? We're going to try to figure this out. Now they're saying, forget the plaque. Just go exercise. Just get out and do something. Prevention is the key. Like Christoph, 30% increase in CAD. I mean, this is amazing. We were doing so great for so many years. This is what we need to know. You need to exercise. As you increase that, your risk of death and MI goes down substantially. In fact, this was done way back in 1986. You had 3-vessel disease. You had a positive treadmill. You had terrible event rates. Bypass surgery revascularization works. But no study has ever said that if you have 3-vessel disease, negative treadmill, you're completely functional, you're asymptomatic, you get your risk factors under control, do you live any longer with anything we're doing? It really is truly a symptomatic disease. So what should we be doing in the United States Air Force? Everybody asks, what do we screen? How's our screening? Our screening is you ask them how they're doing, you make sure they can pass their PT test, you make sure their risk factors are under control. If all that is true and they're low risk, no screening in the United States Air Force. All we do is we do an EKG when you come in the Air Force. We do an EKG every 5 years starting at age 35. That's it, because there's no data that shows that any other study is good to be done in an asymptomatic patient. However, we do have 130 patients in the United States Air Force with CAD. And luckily, all their events, if they had an event, was done on the nights and weekends and while they were doing other stuff. Probably because the 1% rule just means that 99% of the time we're going to be okay if they have their MI in that 99% of the time. So we need to do something. So what I'm proposing to the Air Force, and what we're talking a lot about now, is actually having an official Framingham risk score. Right now in the United States Air Force, if you go in to see your flight doc, you're going to be asked all these risk factor questions. We want to make sure your risk factors are under control. If they're not, then they can do additional screening. It's not mandated, but they will, and most of them will. I get calls all the time. You do a Framingham risk score, there's the Europe score, there's a Reynolds risk score. If it's above 10%, then you're intermediate risk. You need to have something else done. What would be the perfect test based on everything I said today? Calcium score. Calcium score would be the best test. The study that Christoph talked about, the confirmed trial, actually said CT angiography is not helpful in people who have a negative calcium score and Framingham risk. So if your Framingham risk is even in the intermediate risk range, if you have a negative calcium score, there's no reason to do CT angiography. I think calcium score is the best way to go. I can do it in the church parking lot, so I like calcium scores a lot. How about if they're in this, 2B this is a 2B indication by the American College of Cardiology, if they're in the 6%. So this is what we call low to intermediate, 6 to 10% risk. We're working with a high-risk population. Those people should probably get a calcium score too. Not official policy. A lot of flight docs do it. Anybody in the room's allowed to do it. I'm not going to, you're completely encouraged, actually, if you see a pilot to do that. So, echo's great. Echo showed me how the heart's beating. Really hard to tell ischemia unless you do a stress echo. And it's still not 100%. It's 80, 90%. Nuclear is a great perfusion study, right? Tells us all about physiology. And then calcium scoring is great for prognosis. Doesn't tell us anything more than prognosis. Nothing is perfect. And again, what you want to do is you want to be exercising. So what if we did CT angiography on everybody? Well, this is Neil Armstrong. I had the pleasure of meeting him last year at the asthma meeting, and he was found to have significant cardiovascular disease on a screening at age 80. So in his 80s, I think it was 83, 85, and found disease, said you need bypass surgery, did 3-vessel bypass, and unfortunately he passed away due to complications of that bypass surgery just three weeks later. So that was if you would have done CT angiography on this guy many years ago, I'm sure you would have found some non-occlusive disease. So a 40% lesion we're not going to do anything about. So this is Chuck Yeager, which I also had the pleasure of meeting and working with. He has mild coronary disease. We continue to let him fly, and at age 89, back in October. He flew an F-15. It was the 65th anniversary of breaking the sound barrier. He did it again in the back seat of a F-15 at Nellis Air Force Base, and he's still going strong. Everybody knows this guy. This guy also was diagnosed with 4-vessel disease, got bypassed, and actually now has 2 stents in his grafts to his bypass again. Somebody else said if you would have looked for non-invasive, if you would have looked for coronary disease as a young man, you would have found it. And then Tim Russert, which I never had the pleasure of meeting, on Meet the Press NBC correspondent, who had a nuclear stress test done 2 weeks before he was found dead at his desk, had an MI, had a nuclear stress test 2 weeks prior that was completely normal, had a calcium score of 200. So that's a little perplexing. So anyway, let's go back to this question. What's the right answer? If you want to enter the United States Air Force, because we're making it sound like anybody can get in the Air Force now, right? And look, we'll accept you. We'll accept any. The answer is you cannot come in the United States Air Force, become a pilot if you have known cardiovascular disease. So if you have it at a very young age, we're not going to train you. So I hope this helps. I hope everybody will meet me afterwards. We'll do calcium scores and caths over at Launchville this afternoon. Actually, I'm a little jet lagged, so we won't be doing that. Not as many jokes this year. I'm a little tired. Thank you so much for listening.